allowable in any industry whatsoever. So I'm not going to solution. There are many speakers, going to speak. Dr. Kalra is already the big man in the NABH, CEO of the NABH, and if you listen to Bharadwaj, you'll be enamored by the kind of talk he'll be giving you. But only one thing that I'm wanting to tell you is that you should all look after yourselves as CEOs of the future. And there's one Japanese word is that when you become CEOs, Genchi Gembutsu, I don't know. It is called get leaders out of the office. That is, lift your ass and go and see for yourself. Thank you very much.
Thank you, Dr. Bose, for a very passionate discourse and engaging the participants in the real important issues related to quality, especially the happiness of coming to the hospital. Is it there? I think we need to work on that. Technology may be something, professional competence and being a FRCS or like that is something, but is your client happy with you? Has he prepared himself to come back again to your hospital? Is he willing to come? He is not averse to paying you more, but is he interested again to come? That is a very, very important parameter for. So technology may be very important, but I think more is interpersonal behavior and more how can you reduce waiting times and spending time in the hospital, undue delays. And this is such a painful thing, that discharge delays. That is coming more and more now in this business of healthcare. Anyway, so sir, thank you so much. Let me get Dr. Kalra. Dr. Kalra is primarily a pediatrician. He did his MD from Maulana Azad Medical College, and then he served in the government in various positions and worked as hospital administrator in various hospitals in Delhi. Now, very importantly, he holds a very, very important position. He is responsible for leading quality movement in this country, ensuring accreditation, and see that quality assurance measures are implemented in letter and spread. Dr. Kalra is the CEO of NABH and Quality Council of India. Let me request Dr. Kalra to share his thoughts. Thank you so much, sir.
Distinguished dignitary on the dais and dignitary of the dais, good afternoon, everybody. And especially after such a nice presentation, talk from Dr. Bose, I think he has made my work very simple, because most of the data is already shared, and the few key challenges for quality care already has been, some examples have been given. Before we start about patient safety and quality overview, first of all, let's see the healthcare scenario in our country. We all know both the system, public and the private, that works in our country. And for the last few years, more and more private sector is having overedge over the public health sector, to the extent that up to 60% of the indoor care being provided by the private sector. And in the OPD, when it comes, 78% is provided, health services are provided in the private sector. And doctors available, 20% are only available in the public sector, while 80% work in the private sector. And in spite of Indian healthcare industry is seen to be growing very fast in our country for the last few years, but quality remains a serious concern. Affordability, we all know 71% is out-of-pocket expense, probably one of the maximum out-of-pocket expense in the world. And accessibility, where 68.8% of our population lives in rural areas, there accessibility, affordability, and quality is a real problem. And we all know the various reasons. I will just skip few slides because of the paucity of the time. And main challenges in our country, what we used to have earlier, the patient-doctor relationship about 2 decades back. Is it same now as on date? Is it same? Doctor was being treated next to God. But nowadays, when patient and the families comes to a doctor, he wants to argue, and he has a lot of knowledge, a lot of awareness is there, and expectations are very high. They have most of the time they have done Google search, and at times they know more than even doctors, and they want their full involvement in decision making. And healthcare industry is probably one of the most complex. Are we keeping all our medical staff, including doctors, nurses, paramedics, keeping same pace in advancement in technology? New and new machines, instrumentations, equipments are coming almost very fast. Our medical staffs are being trained to update themselves to deal with those newer technologies? Very few. Then advancing age, geriatric problems, definitely, and most important, as already Dr. Bose has said, in our medical curriculum, nursing curriculum, and paramedical curriculum, there are no patient safety and quality concept as well as soft skills are being taught in the curriculum. We have been talking so many times with the MCI for a number of years. In principle, they've agreed to include those in the undergraduate curriculum. But when they will be implemented, God knows. And already data has been enumerated. It's unfortunate that in our country, the magnitude of the problem, no national database is available. We all have to depend upon data from developed countries. And most of the developed countries, similar data is there for regarding medical errors. 1 in 10 adult contract infection in a hospital when is admitted. 1 in 10 patients receive wrong medication or wrong dose. And if we see the number of deaths already has been highlighted by Dr. Bose, and latest report from US is more than 2 lakhs annual deaths due to hospitalization errors. And this, when we just do the risk of dying in healthcare, we see the chances are 1 in 300. And while in aviation industry is only in 1 in 10 millions. Means health industry is probably one of the most dangerous industry to work in. That's why we need to improve our services. This slide data is from Dr. I have taken from Dr. Devi Shetty's slide that every 10 minutes a young girl dies during childbirth, and about 3 lakhs children die that day they are born, and 1 million babies die every year before they reach the first birthday. That is the magnitude of the problem. And this important saying, ignorance is bliss. Once we are not aware about the problems, if everyone feels everything is fine, why we should work about quality? I have a number of patients, I am overburdened. A lot of patients are coming to the hospitals. Why I should worry about quality? This is ignorance. Once we know there is evidence to demonstrate, no, you are not doing everything is fine, then they realize the need for quality and patient safety. Patient safety is a global concern. It's not only in developing countries, but rather in the most advanced countries, still that is a global concern. And most of the countries have established systems for quality services, and some are in process of ensured safe care. When we talk about quality, this is about a change, and basically change in the mindset, attitude, and behavior. That is the most important required to bring a change in this. And various national and international forums are working on patient safety goals. And most common this patient safety goal identified nationally as well as internationally are patient identification. How many hospitals they use a system for right patient identification? Before this accreditation, hardly there was any system being followed. Improve communications and handoff, then medication safety, prevents hospital-acquired infections, identifies patient's risk, and prevent wrong site, wrong patient, wrong procedure, fall prevention, and patient satisfaction. These are the few common patient safety goals. We have to work for that. And drivers of patient safety, which can promote this quality and patient safety, the professionalism, the various professional organizations, associations, they have a big role to play in patient safety and quality in healthcare. These associations, professional bodies, they can form the standard treatment guidelines, the protocols, they can convince, motivate the members to follow the ethical behaviors and adopt professionalism while they are practicing. Then regulations and consumer protection has a big role to play in promoting of quality and patient safety. Then market forces, the competitions, the insurance sector in our country, the private insurance sector, even on today, is hardly not more than 7%. And we combine all government and private, maximum 35% insurance coverage is there. Then public demand, probably this is the biggest driver in the coming times which will bring a change in our system. Whenever people go to market to purchase anything, they look for quality. Are their patients and their families also looking for quality mark in when they go for, they need a some health in the medical facilities? But now the amount of awareness, people's expectations we see, the number of complaints now we are getting at NABH from different sources regarding accredited hospitals, even non-accredited hospitals. People expectations are very, very high. Their awareness levels are very high. They know their rights. And probably this is the public will demand and bring a change in our healthcare system, and quality and patient safety levels will go high. And most of the researchers, they have found the reasons for these errors. And communications problem, the lack of proper communication, clinical communications or even non-clinical communication. This is the most important factor we have to address. How to improve communications. Even documentation, writing medical records is also comes under communication problems. And already this has been explained by Dr. Karan Jakar in detail in the morning. The Swiss cheese model, basically it is a system. No individual is to be blamed for a medical errors. It is a system failure. We have to attack the systems. Under the systems, the committed leadership, which is the most important to drive a good quality healthcare. And other things, detail has been discussed. I will not spend much time on this slide. And we know that human beings commit mistakes because the systems, tasks, and processes they work in are poorly designed. And definitely when we talk about patient safety, it's not only safety of the patient, it means safety of the healthcare staff as well as visitors attending in the hospital. We need to have a safe system for them also. And we mean that adopting through adoption of management of evidence-based practice, processes, and systems, only then we can ensure a patient safety and quality. And there's a need for a call for action. For that, political administrative commitment to make patient safety a priority objective in the public health system is the need of the day. And developing safety culture in the hospitals, involvement of the patients and the families by raising effective communications and sharing of best practices and data collection. Accreditation has been proven a trusted tool for quality improvement and patient safety. All over the world, most of the countries, now they have adopted accreditation as a good quality tool for improvement in healthcare services. Accreditation stimulates in healthcare organizations a safety culture. It improves the communications, medication safety, the provides framework and physical environment that supports the safe delivery of the care, infection control and prevention, and risk assessment and best practices to be followed in accredited hospitals. 7 steps to patient safety are: build a safety culture, lead and support your staff. This is the role of a leadership. Integrate your risk management activity. Before this concept of accreditation, hardly there was any building rounds or risk assessment management being done in the hospitals. But now accreditation is very important to integrate risk management and must do a periodical check for that and promote reporting of adverse event. It's not only promotion, this reporting of events, rather analysis and doing the root cause analysis so that we can take corrective actions and these errors are being prevented from recurrence. Involve and communicate with the patients and the public. Learn and share safety lessons. All these errors, they should be shared with the different stakeholders, and then we should be ready to improve. Implement solutions to prevent harms between safety designs. And how we can achieve this is standardize everything. Standardize the processes, the treatment guidelines, and various procedures required. Make protocols, the checklist, reporting of errors, learn when things go wrong. And this is a simple example of surgical safety checklist by WHO. This can be modified as per need, and if it is used 100% in an operation theater, almost 80% of the surgical anesthesia-related adverse event can be prevented. This simple checklist before even anesthesia is given, before skin incision is given, and before patient leaves the OR. If these things are verified and documented, even accredited hospital, the 100% compliance is yet I have to see. Training. So far, training were hardly being done in the hospitals. But training definitely is the need of the day. Trainings even can improve the weak persons, even weak athletes. They also win the race by persistent, continuous, vigorous trainings. Same way, training should be a part of every hospital functioning. And training should be induction training, need-based training for skill development, training for continuous improvement, and soft skill training, especially the communications, because communications is the major root cause. We must take all actions to improve communications. And human healthcare quality, when we say, it means doing the right thing the right way at the right time, in the right amount for the right patient, that does not result in harm to a patient. And domains of the quality care are care which is safe, effective, efficient, patient-centered, and what is new added now, family-centered. It's not only patient-focused, now this is family-focused. It is equitable and it is timely. The various initiatives are being taken at different levels. In the government initiative, we see the health is a state subject, under the NABH and even various regulations at the central and the state level, like biomedical waste management and the Clinical Assessment Act and draft national new policy. They all speak about universal coverage, affordable and quality care. But progress shown by the state health facilities is very, very slow pace. If you see this, a new initiative of the government, the Kayakalp program. Kayakalp means to bring a change. This has been linked with Swachh Bharat program, Abhiyan, which was launched by our Prime Minister on 2nd October 2014, which focuses on promote cleanliness, hygiene, and infection control practices in public health care facilities, because hospital-acquired infection are one of the major concerns. And this program deals with that also in that way. And further incentives have been now, there's a provision for incentives for the best hospitals in the district and the states. And the incentives are a very high amount, so that all hospitals, they take initiatives to improve the healthcare quality services. When we come to the accreditation, already I have discussed accreditation is a trusted, well-tested tool. And we say about when accreditation, it means quality and accreditations are interlinked. When quality systems are in place, that hospital is prepared for accreditation, And when hospital is preparing accreditation or is accredited hospital, it means quality and patient safety systems are in place. Accreditation is enabler of change. It's usually a third party and voluntary. But now, few countries are making this a change. It's becoming mandatory. And NABH in our country, National Accreditation Board for Hospitals and Healthcare Provider, is responsible for bringing a change in the healthcare scenario in our country. And NABH is one of the constituent board of Quality Council of India. It was set up in 2005 and is a not-for-profit organization. Accreditation program was started in 2006, and it is a voluntary participation like any other accreditation program in the world. And NABH standards are having international linkages also. The NABH hospital standards are accredited and recognized. NABH is an organization, is accredited by ISQA. ISQA is an international agency for quality improvement, which accredited JCI, Australian standards, as well as same standard. NABH standards are also accredited and recognized by the same international agency. It means we are working not only in India, NABH is working even beyond the borders. We have 4 centers accredited by NABH standards in the Philippines, and a few more applications from Doha and SAARC countries are in pipeline. And various programs for accreditation we run is the accreditation of hospitals, accreditation of blood banks, small healthcare organizations, nursing homes, and then accreditation of OSC centers, PSCs and CSCs, and Ayush hospitals. Ayush means Ayurveda, homeopathy, yoga, naturopathy. Even we have a system of accreditation for those alternative traditional systems also. And accreditation of wellness center and medical imaging centers means standalone CT scan, MRI centers. And then allopathic clinics also. In the new programs we are going to start very soon on the request of the government, that is accreditation system for clinical trials, because India is a large potential for clinical trials, but due to some challenges, for the last 2-3 years, clinical trials are on decline. That's why a new system for accreditation being just to streamline the procedure to ensure that all the clinical trials are conducted in a good atmosphere, in a good ethical way, and then this system will definitely promote more trials in our country. In addition to that, very soon we are going to start a program of certifications for emergency department of the hospital. These standards are already available on the website for public comments, and probably in a month's time, we'll be launching this program in collaboration with the Academic College of Emergency Experts, R&D Institute. And these accreditation standards, there are 10 chapters of NABH hospital standards. Of these, 5 are patient-centered, and rest 6 to 10 are organizations-focused standards. And what does NABH means? We know that commitment, it means when a hospital gets NABH accreditation, it means commitment to create a culture of quality and patient safety, establishment of protocols and policies as per national and international norms, and patients are treated with respect, dignity, and courtesy, and patients are involved in their care planning and decision making. Patients are being treated by qualified and trained staff, and feedback from patients is sought, and complaints, if any, are being addressed. Transparency in billing and availability of tariff list is there. Continuous monitoring of services being implemented for improvement, and commitment to prevent adverse events that may occur. No one guarantees accreditations by NABH, by JCI, or Australian, Canadian. No organizations guarantee there will be no adverse event. But there should be a system to detect them and then to take corrective actions. And if you see the trend overall for the last few years in our country, the number of hospitals being accredited is very, very encouraging. As on date, there are almost 360 hospitals are accredited by NABH. And if we see all facilities, healthcare facilities accredited are certified under various programs in the country, there are 626 today. And out of this 626 figure of certified NABH certified healthcare facilities, if you see the public sector are only 59. Rest are all from the private sector. And if you see the geographical position in our country, almost all the state, cities, applicant hospitals, accredited hospitals are there, and even from Northeast, as of date, 2 hospitals are accredited under various programs. An audit cycle, once a hospital gets accreditation certificate, that's valid for 3 years, and during 3-year period, from 15 to 18 months, is surveillance activity, surveillance assessment is also being done. In addition to that, at the end of the validity period, 3 years, again a complete assessment visit is there. In addition to that, for last 1.5 years, a system for surprise visits also being introduced. Surprise visits are being done every month on a random basis, as well as on the basis of feedbacks and complaints we receive from various resources, so that continuous compliance with the standards is being maintained. And as I said, only as on date, 360 hospitals are accredited. And in our country, we all know more than 60,000 hospitals and nursing homes exist. Then what to do rest of the hospitals? A new innovations we have done, and we have come out with now a stepwise approach. We have come with 3 levels of certification. The top one is the full accreditation with the red color, and in between is progressive level, and the lower down is the entry level, pre-accreditation entry level. In addition to these 3 more programs, SafeEye, Nursing Excellence, and Laboratory Improvement, they have started. The SafeEye deals with hospital infection and control prevention program, which is chapter 5 of our main standard. It is done in collaboration with BD, and now this is picking up very fast. And second, nursing excellence. If you are able to improve the nursing care across a hospital, it means 80% of the job of accreditation we have achieved. So these various steps we have taken so that more and more healthcare facilities, they join the quality journey in our country. The entry-level standards, they have been derived from our main accreditation standards, but if you see the number of standards, existing full accreditation standards, they have 10 chapters, 102 standards, and 636 objective elements. While entry level, same 10 chapters, only 45 standards are there, and objective elements are 167. But these number of elements are enough, as these are minimum essential objective elements standards required for patient safety and quality. At least hospitals, they can start the quality journey, achieve a level, then after a year or 2, they aim higher, their targets are high, and they then look for higher progressive level or full accreditation. This is the approach. And when full accreditation, the 64 indicators every hospital has to capture and analyze and take corrective actions. Out of 64 indicators, key performance indicators, 11 are the mandatory indicators. They have to submit to NABH every quarter. Then feedback is given to the hospitals. What is their need, how they should, where they stand against the national and the state average, what action they should do to further improve their quality and patient safety required. These are examples of those data being sent to us to every quarter to us. And this is a web. We can see the particular hospitals, where that hospital lies against the national average and the state average. These are the national. Now we are gathering data, but validation, integrity is still, I will say, is a question mark. Because type of data we are getting needs to be validated. But gradually, the quality of data we are getting from the hospitals is improving. Maybe next year, much more data, authenticated data will be there to analyze and present in the public domain. And take-home message is take initiatives for safe patient care, introduce quality in everyday activity, think about accrediting your organizations. Remember that simple measures save lives. Remember those measures. And reasons for us being here together is to create awareness, because all you are the future hospital managers. Definitely you should be all prepared, aware about the need for quality and patient safety. And then there should be a commitment, will to change, to identify problems and challenges and understand the causes, develop solutions and implement change and embed in everyday practice. The quality systems we are talking about, they should be part of the habit. They should be internalized. It's not should that inspection is due next week, then only you start preparing. But it should be part of the habit. Any time of the day, any day, any month of the year, the hospital should be ready for any assessment or any inspections, so that systems are in place. And then monitoring is very, very important. This is very important slide, empathy. What is the most common complaint from public? There is no concern being shown for our patients. And I always say is that empathy in our country existed, but it must also continue to exist. All patients and the families should be shown the due concern, and they should be treated in empathy, with full empathy. Remember that bad systems, not the bad people, are responsible for the most of the errors. Do remember, you have to change the system and propagate the safety design. The people's base, patient safety, is all we have to work together to bring a change in our healthcare scenario, so that we also we lead the world as far as healthcare quality is concerned. Thank you.
Thank you very much, Dr. Kalra, for very elaborate discourse on concepts of quality and then patient safety, and then how do we go about and what systems have been created to ensure quality care in hospitals and healthcare organizations. We are very thankful, and on behalf of our students also, I would like to thank you to give them exposition to NABH and what general procedures are. So thank you very much. Let me now invite Dr. Bharadwaj. Dr. Bharadwaj is the Vice President Operations, Medica Hospitals Private Limited, Kolkata. He has been previously serving as Marketing Head and member of Central Operating Group at Medica Operations. He was Medical Superintendent at Medica's Super Specialty Hospital. He was Chief Operating Officer at the Medica Pharmacy Private Limited. He was Administrator of Max Medicenter, Max Healthcare Institute Limited, and Head of the Marketing Fortis Hospital, Noida, and worked as Senior Manager Operations at medlife.com. We look forward to hear you from sir. Thank you.
Thank you, sir. I'm the last person today to speak, so I'll make it very quick. Nevertheless, when I was asked to come in and make this particular speech, lecture, whatever, so I just did a little bit of search on the net to see what is the vision and mission of various big, powerful, important establishments, hospitals in the world. And I realized that only 3 of the vision mission statements that I read, amongst say 15, they had the word safe in them. And mind it, these are some of the bigger and the best hospitals of the world. Many of them are in India. So what I realized, that the vision and mission statements from international quality and affordable care, as we moved on, suddenly the importance of safety became prime, that we were supposed to give it a proper name in our mission statements. That's how now safety is coming back into the forefront. I remember that when we were doctors, we were told that do no harm. I think that's why Hippocrates, sir, I think many thousands of years back had actually suggested, which today we are following in a different way by calling it patient safety. Okay. So safety is infrastructure, process, clinical, paraclinical, administrative, and then of course there's a behavioral and environmental thing. Infrastructure, as Dr. What was his name? Karanjikar. Do not make a hospital without looking at NABH recommendations. This is one line. We all have, retrospective knowledge. I mean, that wisdom is there now. I think the biggest challenge right now for NABH accreditation is infrastructural compromise being made when the hospital was being made. That's very important. you have processes, and then you have behavioral environmental issues. This is how an ICU looks. And if you will read Mr. Gawande's book, he said that in 1997 research clearly said that 178 procedures are done in a patient who is in the ICU per day. And 2 mistakes are made. This particular patient has almost all the machinery, and this is a reality. When you go to a good hospital's ICU, you will see almost 90% of the machines on the patient. So this is the complexity. Our attitude normally has been that quality is more of a clinical care quality, but as Dr. Bose said and Dr. Kalra said, actually it is a lot to do with non-clinical processes and support. Human factors have already been mentioned. The slide is a repeat of what Dr. Kalra said. Identification of patient is a prime importance. It is nowadays very simply solved by putting a band which can't be removed on the patient's wrist. Earlier it was done for babies. When the babies were born, we used to give them a band. But now everybody gets a band. I think that's very innovative. It solves the problem. It comes for 60 paisa. Just do it when you go to hospitals when you are working. Hospital facilities have to be safe, they have to be clean. These are all stuff. And there is something known as a clean environment also includes good hand hygiene. I think everybody has seen this particular diagram. When Dr. Bose was showing his hands, I thought he was saying this is the main reason why people get infection. But he said it's about doctors. Sir? Yes, sir. So devices, everybody knows, just pay more money, you will get best of devices. So let's not talk about it. But I thought this was very, very important, and I want to read it out to you. You see, the quality and safety culture of an organization is a product of individual and group values, attitudes, perceptions, competencies, and pattern of behavior to determine the commitment to and the style and proficiency of an organization's health safety management. It has told nothing else. There is no device. There is no hand cleanliness. It is just talking of something which is very basic. Organizations with a positive quality and safety culture are characterized by communications, as rightly said by Dr. Kalra, communications founded on mutual trust. The biggest problem today with our youth is there is too much competition and too little mutual trust and respect. They can both coexist. It can be shared by perceptions of the importance of safety and by confidence in the efficacy of preventive measures. Everything is actually preventive measures. So I'll go back to my previous slide. Infrastructure, process, behavioral, and environmental issues. Should the slide be actually like this? In my experience, I have realized that processes within the hospital, and they may change from one hospital to the next, are largely influenced by the human beings who make the process. I'll give you an example. If you will ask ops to make a process, all the work will be with the nurses. If you ask finance guys to make a process, all the work will be the ops. You see? The biggest problem today we all face, and we have to come out of it, is very simple. Do not think within the boundaries of your own department. Once you are given a task of a process which actually determines the quality of care you give to the patient, it is many things. So you have to have a very holistic view. And that's the promise you guys are going to make to yourself. When the process is being made, there is only one central issue, the patient. If you will keep it that way, you will have no problem. That's a promise. So what am I going to do today? The best of the best were here. They've already told you everything. So I'll just tell you what is there at the ground level. Fine? So it takes me back to this slide. Everybody has seen the slide? Right? एक चीज बताओ, नल कौन बंद करेगा? यस, यस. ये वाला नल कहाँ होता है? ये वाला नल खाली ओटी में होता है, कुछ हॉस्पिटल्स में शायद वार्ड में भी होता है जहाँ पे हम लोग हाथ धोते हैं, पर नल कौन बंद करेगा इज अ क्वेश्चन आई कीप ऑन आस्किंग माई सेल्फ, एंड इट इज अ बिग टाइम क्वेश्चन बिकॉज मोस्ट जी somebody said something? All these are there, but actually in reality, if you go out of any metro, you'll not get the sensor taps other than and toilets of the airport. That's where they are, and 5-star hotels. They're not there. So the slide should have two more these things. One is that you got to have towels. You wipe your hand, close the tap, and throw it. But this I have found in no schematic representation. Okay? So always challenge what is being thrown at you. All that everybody has told you today is challenge what is being thrown at you. You know, you can make it better. Do not take everything, on the face value. So I go back. Okay. Now, from safety, where will we go? I think we'll go to patient well-being. And when you will do for operations, you will realize one feedback which gets no care is noise in the hospital. And when it comes to noise, and I went to noise problem, and I went to the floor, and I asked you, what is this noise problem we are facing? Is it the nurses who are shouting on the top of the voice in the evenings, in the night, when the voice levels are very low and their voice travels? Actually, it is much more. It is actually the staff who opens and closes the doors. The tuck sound is highly irritating, and I personally interviewed many patients. So it was the opening and closing of doors, but the biggest killer is the nurse calling system. In the nights, it is the biggest killer. So what is the solution? You turn it off in the nights, and you have bulbs, the old system of indicating that some patient requires a nursing care. How would you take care of the banging doors? 25 paisa solutions. You hang a piece of cloth, a little bit of cotton from the door handle. It comes between the banging doors. Is that enough? It just came to me today when I was making the presentation. Most of the times we can actually remove the door. We don't need the door in 85% of places where they are. Anyway, we can come to that later. With this presentation, what I am trying to tell you is the problems you're going to face on the ground, and you will have to devise your own strategies to solve them. NPM is a very big problem. Nil per mouth. Nil per mouth is a standard OS for any person who's going to the OT. And Dr. Bose would agree with me that the OTs can sometimes get delayed. And there is a huge problem about these patients. They have to stay hungry for a longer period of time. Most of you will get into the hospitals and you'll realize that these feedbacks will continue to come to your table very often. But NPM and insulin patients are a very dangerous mix, and you'll have to devise your own strategies to deal with them. Why I'm talking about all these things? You see, a lot of people came from preventive and primary health care. Problems are similar everywhere, and you will face these problems, and you will have to address them. Another problem which you will face is cultural problems for patients. But I realize in meetings, and which really affects our data collection, our reporting, our root cause analysis, sir, is that everybody has different meaning for the same word. You'll be surprised. You have a morning meeting with 30 people who are your heads of operations, and you ask a simple question, and everybody says the answer which seems to be the right answer. But you ask the second level query, and they have got their own meaning of that particular word. So it's very important to do the second level analysis on something which is very mundane. I'll give you an example. Billing ho rahi hai. Dr. Karanjikar said that Fortis Hospital, I was also part of Fortis just after he left, they took 6 weeks to give one single bill which was absolutely correct. Can you believe it? 6 weeks. It was challenge sent to Mr. Sunil Kapoor. But it's true. That's the kind of challenges you face when you start a new hospital. So the chairman asked, entry ho rahi hai package mein? Very interesting, sir, because I just saw that proper billing is also now part of NABH. So, हाँ sir, billing हो रही है. First answer. So, दूसरे से पूछा, billing हो रही है, update हो रहा है, हाँ sir, billing भी हो रही है, update भी हो रहा है. Now the first guy, when I said billing हो रही है, he means that he is keying the entry. When we asked update, we meant कि it goes from the billing into the package so that it is not being charged. But the second guy also said update हो रहा है because he also meant कि billing हो रही है. You know? And we asked 3 people, we got 3 answers, but we continue to understand that sometimes the feedbacks we are getting is because the billing which continues is not put into the package at the end of the day. And this was my chairman asking. So we had a good laugh and he said, my God, it happens to us every day. The same words means different things to different people and it's a big, big problem. Besides that, the cultural issues at patient levels become very big problem because they have their own beliefs. I'll come to that a little later, what I mean by that. But if you're talking of patient safety, and it'll come to you very often, and you'll not find it in any of the books, your windows shouldn't be unlocked. Okay? Your doors should not be lockable. Patients lock themselves and they attempt self-injury. Very common. All of you will come across these things, and I've seen many hospitals who actually don't lock their windows, and you will get into a lot of legal trouble. I'm just giving this as an example because these are something which you're not told about. It's very important that when in the ER, when you get these kind of patients, their psychiatric and psychological analysis is done well, documented. All the administrators have to know about it. Very, very, very important in lives as administrators. Nobody wants this kind of incidents to happen, but in lifetime, you may come across many such incidents. Sir mentioned, I also mentioned, ER policies of the hospital are very, very essential for the safety of the patient. Patient comes with head injury, half the time goes, ki paisa kaun dega CT scan ka. Do you know that? That's reality. A good policy is, you do the CT scan, it's only 1,000 rupees. At best, we'll lose 1,000 rupees. But that actually decides whether the patient actually needs treatment. A very simple ER policy, and I've seen it in every hospital I have worked, that it was to be attended to and changed. Be it Fortis, be it Max, or at Medica, because Medica had already done it, so we made it happen. ER policies of door to the table, primary PTCS, is a big reality and a necessity. All these PTCS happening, the angioplasties, in many, many cases, you can actually remove the clot and not have the heart attack itself. You save the heart. Here, the administration has to play a very important role. Gaadi nahi milti hai. You'll be surprised. Half the time, the doctor is ready, but gaadi nahi hai, sir. Idhar gaadi, udhar gaadi, kaun dega, aega. I mean, it's crazy. You know? So what is the idea? You're saving a person's heart. He's not going to have a heart attack if he's picked up or comes to the lab and you take out the clot and he's perfectly fine. But he is caught up on some administrative issue called cost of travel, or I have to take a taxi to get the doctor. He's got to take 3 people. So empowerment is very important. Decision making is very important. And it's got nothing to do with clinical. The doctor is ready. Even with willing doctors, you'll not be able to do a primary PTC at times. Okay? So these are some environmental issues, beliefs, and changes and quality issues which you have to keep in mind. Training. Oh, everybody talked about training. Every hospital does training in India. Retraining in India. Please go and visit a training session. First mistake all of us make is those people who are responsible for the bad training are also retraining. And they say that the staff and the students are bad. Yeah, I agree. The quality, because of mass production, is not there. But the kind of training you're giving is antique. Nobody can learn that kind of training. I was again and again seeing these nursing problems when I was medical superintendent. So I went to मैंने कहा चलो आज मैं जाके देखता हूँ. My God, उस training से it's all theoretical. It really doesn't make sense. There was a big big thing about code blue. When code blue happens, patient is dead or dying, you respond and there is a ER guy running, there is a defibrillator coming, there is a crash cart coming, and there's a big hoo-ha happening about this saving process and all, which is a very good thing. I just asked one day, okay, how many code blues? Okay, we had 5. I said, how many code yellows? And everybody looking at me. I said, why not code yellows? What's a code yellow? Code yellow is a deteriorating patient. I said, if you have a fantastic code yellow regime, code blues will be 1/4 to 1/5. You know? But because NABH wants code blue at its best, everybody is working on code blue. I said, I want to know code yellows first. So when there's a quality meeting, I say, tell me code yellows. How many code yellows have you had? It's a very simple, implementable plan. It works very well. So these kind of questioning, because I am not trained. I was never NABH trained, although I went to the training and I went for the advanced courses. But just because I'm always there and I'm always looking at things, this kind of inquisitiveness you have to have in yourself. And please ask stupid questions. It will make you very intelligent. Keep on asking. I'm very famous in the hospitals for asking very stupid questions even from the mic. I really don't care. Because I want to clarify the doubts and I want to understand what matters. Another 2 minutes. Admission routines we can leave. Needle stick injuries never happen because you're trying to recap. Needle stick injuries happen because the housekeeping staff puts her hand in a place and finds the needle when the needle was not supposed to be there. Recapping days are over. It's the throwing out needles and here and there, which is a big problem in our lives. Bed sores, big problem. We can skip it for another time. Falls. Falls in a hospital should never happen. As far as you're concerned, 2 things I'll tell about falls. One is that the patient and the cultural background will not like to, have defecation and all on the bed. And you will have to stop them going on their own to the toilets. Most of our falls happen between these 2 points. A very important feedback from people who are working in the hospitals. Other feedback, please have handlebars in the toilets. Most of the people who fall are because when they're getting up, they push, they get up, they don't have a right thing, and they fall. Falls very sensitive, 0 tolerance, and I always say, if there's a fall, I will personally do RCA myself. Somebody mentioned, there was a very good poster. I made these slides as I went around, so it was not much time has been there, so quality is a little bit poor. Maintenance schedule, there was something about 20 to 80% the failure is in the maintenance. Actually, the failure is not in the maintenance. Where is the failure? Failure is, sorry, not transport. It's a purchase department. Most of the time, what we see when we work and make our hospitals and our organizations, purchase department is never part of any meeting. When everything comes through the purchase department. Dr. Saumitra Ghosh talked about the availability of medicines as a very, very crude and very real example at what happens at Bardmer, Jaisalmer, etc. But it happens in every hospital. Half the delays of maintenance are because of purchase department still getting quotes. In the organizations, they should be given 2 to 3 days to get their quotes. Otherwise, they will be overruled and they will be told they are not performing. Quotes sometimes takes 2 months. You'll be surprised. These habits, these practices have to be totally removed. All quality meetings have to be mandatory, regular, printed, and put on the board. If you'll not do this, quality is not going to happen. I can guarantee you. Quality is the prime objective of the senior management, and they should be at it. And if something goes wrong, they are to be blamed and nobody else. Last and foremost, 1 minute. Okay. Feedback. One feedback came कि खाना में problem है, खाना में problem है, खाना में problem है. It was about quantity. And I kept on saying कि अगर 3 times अगर feedback आ रहा है गलत, then there is something basically wrong. What you will see that we have become experts in giving post-mortem reports. all the reports are post-mortem. ये हुआ, ये हुआ, ये हुआ, ये हुआ, इसके कारण ये गलती हुई, उसके कारण वो गलती हुई. There is a time stamp. It really doesn't work. It's useless. If it does not tell you why it was done and how it can be prevented, it's a useless thing. 99% of what you get on emails is just post-mortem. I said 3 times there is a problem. Look at the problem. Why is this person saying quantity, quantity, quantity mein kami hai, kami hai, kami hai? What we realized, a new bowls had come for the measure, and they were of smaller quantity, the smaller size. But just because you are digging, I said, if this patient is given a feedback, there's something wrong here. 3 बार नहीं आ सकता, 3 different people. That sensitivity, if you will not build into your system, into yourself, you will never be able to really improve the systems which you so want to improve. Couple of things. My request to all of you, to develop this kind of thought process, I can recommend you 2 books. One is from the system, a doctor, he wrote a book called Checklist. It's a very good book, Atul Gawande, please buy it and read it. The other one is The Goal, which was written by the master of theory of constraints, Eliyahu Goldratt. It is about manufacturing. But if you read that book, it is a fantastic book to build in yourself the problem-solving abilities and the thought processes. And the last one, being a doctor, and what Mr. Rakesh, the health secretary, said about adolescent inactivity, all of you are going to promise me that at least every day, you're going to do 20 minutes of intense exercise to take care of yourself. Thank you.
Thank you so much, Dr. Bharadwaj. Beautiful frameworks, excellent statistical models of quality control. But I think the brass tacks he has come out with is the actual, the crux lies in actual implementation and the key issues that keep on coming in and that disturbs the minds of the patients, attendants, and also the staff, the employers. I think these are some of the key points one need to keep in mind. But to me and to all of us who are sitting here and many in the audience, technology is very important, no issue. We accept. Medical doctors, technicians, all are very important. They are needed. But I think most important is, for particularly quality, is building a culture for quality and changing mindsets of people, not only of the doctors, but down the line who is sitting at the gate, who is guarding the gate of the hospital. So when we talk about leadership, when we talk about quality culture, it's not at the top level only, but at all levels, and they should be part of all meetings or quality teams in any hospital or healthcare organization. With great difficulty in last 20, 25 years, we have to come and understanding what is quality. I remember when 1990s, when quality as a concept was introduced in healthcare, we hardly had any understanding of quality. But I think over a period of time, we have understood it. We have also understood what is quality. We have also understood what are the frameworks, how this can be done, what are the systems, and what could be the processes to improve quality.
To present a memento to Dr. S.D. Gupta for chairing the session.
Thank you so much, sir.
Thank you, sir. As we are running short of time, I'm sorry we will not be having a tea break. I request Arushi to continue the session. So kindly be seated.
quality.
President, the IIHMr University, Mr. Samuel Mount Janet's Chief Field Officer, UNICEF, Rajasthan, Dr. Suresh Joshi, Professor, the IIHMr University, and Dr. Anup Khanna, Professor, the IIHMr University, to come up on the stage. Moving towards the closure, may I now request Dr. Anup Khanna to kindly summarize the conference.
Good afternoon, everybody. So we are nearing the closure of 20th International Conference Pradanya 2015, themed on Universal Health Coverage Roadmap 2020. The proceedings of the conference started with a pre-conference workshop on 22nd October, which began with a very enlightening and inspiring talk on Gandhian views on health by Professor Naresh Dadich, Vice Chancellor of Vardhaman Mahavir Open University, Kota. It was followed by a talk on road safety injury by Dr. Maya Tandon and another talk on human resources and health governance by Mr. Bijendra Vats. The inaugural session of the conference was held yesterday. Dr. Rakesh Kumar, Joint Secretary, Ministry of Health and Family Welfare, was the chief guest, and Mr. Sudarshan Jain from Abbott Healthcare was the guest of honor in the inaugural session. Dr. Kumar emphasized the relevance of the theme in the current context and vividly captured the challenges and important factors required for achieving universal health coverage. Day one had 3 technical sessions. The theme of first technical session was universal health coverage, equity lens, increase access, affordability, and availability of healthcare. The session was chaired by Dr. Girja Devi from UNICEF. Key speakers
Dr. Khanna, can you stop? I have a very humble request to all the audience here not to make movements anymore. Please bear with us. Please.
So the session was chaired by Dr. Girja Devi, UNICEF Country Office, India. Key speakers included Dr. Arina Pavia, Dr. Chandrakant Laheria, and Dr. Daniel Alba from WHO Country Office. The speakers touched upon the concepts of universal health coverage, SDGs, urban health, and health need assessments. Session 2 was focused on drug innovation and patient regime. It was chaired by Mr. Sudarshan Jain, Abbott Healthcare. Dr. Nirmal Kumar Gurbani, Professor IIHMr University, was the co-chair. The speakers included Mr. Sandeep Kumar, Dr. Nanduri Srinivas, and Mr. Vijay Sharma. The speakers highlighted issues related to patent regulations, protection of intellectual property, and prospects of innovations in healthcare. The third session with the theme Reducing Cost of Healthcare and Financing was chaired by Dr. Karanjekar. Dr. P.R. Sodani was the co-chair. Dr. Vivek Desai, Mr. Anirudh Chakravarti, and Dr. Anup Daga were the key speakers. The experts emphasized on improving the overall efficiency by reducing cost through very simple interventions in day-to-day operations. Proceedings of day 2 started with the 4th technical session on operations management in healthcare. Dr. Sunil Kapoor, CEO, Eternal Heart Hospital, chaired the session. Dr. Dhirendra Kumar, Professor, IIHMr University, was the co-chair. Dr. Ravindra Karjekar and Dr. Suresh Advani were among the experts who delivered talk. The speakers highlighted the key components of operations management in hospitals, including finances, materials, human resources, quality, and patient safety, and emphasized that the patient satisfaction is the central to overall operational strategies. 5th technical session was on blue ocean strategies in healthcare. The session was chaired by Dr. S.K. Puri, advisor, IIHMr University, Dr. Anil Agarwal, health specialist, UNICEF, Dr. Saumitra Ghosh, CEO of Wish Foundation, and Mr. Rahul Sharma from Wish Foundation were among the speakers. They talked about very recent but quite upcoming approach of blue ocean strategies in healthcare management, and the sessions were very interesting. The 6th and final technical session was focused on quality and safety in healthcare. The session was chaired by Dr. S.D. Gupta, President IIHMr. The topic is very close to his heart. The key speakers included Satyajit Bose, Dr. K.K. Kalra, Dr. Saumitra, Bharadwaj. The speakers emphasized the importance of quality in hospitals and healthcare institutions, standards of accreditations, and how it can optimize the efficiency and patient satisfaction. Overall, the sessions were very interesting and exciting. We can see from the faces of the audiences. Thanks a lot. Thank you.
Thank you, Professor Khanna, for a quick summary of 3 days proceedings, right from pre-conference till the last session today. Thank you so much. May I now request? Are you going to request? Okay.
I congratulate all the enthusiastic participants who have been contributed towards the momentous success of this conference. Your valiant efforts have pushed this conference towards new glories. And it is now time to award you for your meritorious efforts. I invite Dr. Neetu Purohit to kindly announce the result for the poster presentation. And I request Mr. Samuel Mounganitz to kindly award the certificates and the cash prize. Here are the results.
Just announce the first name and team member. First or last, Dr. Lavina, the ones that are the ones that are okay. Lavina and team. I start with the last.
Hello, good afternoon, everybody. I was fortunate among the panel to review the posters, and I really thank the presenters because a few of the posters were really thought-stimulating and used a scientific approach. And as I requested when I reviewed, and I requested again, that please develop them as papers because the knowledge is to be shared. So I'll start with the results, and I'll start on the reverse order. The third winner is Ms. Akshita Shah and Kajol Shah from IIHMr Jaipur. The second winner is Mr. Sumit Kumar and Manoj Kumar Sharma from Punjab University. Oh. Okay. Mr. Sumit Kumar and Manoj Kumar Sharma. Any takers from them? No? So they've left probably. The first. The first winner, again from IIHMr Jaipur, Dr. Lavina Mulchandani and Preetam Shekhawat. Okay. Thank you.
Thank you, ma'am. Congratulations to everyone. May I now request Dr. Sadhu to kindly announce the result for the paper presentation.
Okay, now it is the turn of declaring the winning prize for the paper presentation. Before I declare, let me thanks and congratulate all the jury members, namely Dr. Alok Mathur, Dr. J.P. Singh, Dr. Binod, Dr. Silpi, Dr. Sanjul, and Dr. Neetu Purohit, Dr. Monica, Dr. Seema Mehta, Dr. Abhishek, Dadich, Dr. Saurabh, and Dr. Sandeep Narula, who have really worked hard to evaluate your paper and poster. Okay, the paper presentation winner, the second runner-up is Dr. Amanpreet Kaur, Doma Sirpar, Shirish Dhora, and Vijay Master. All should come. There are 4 authors. They are from IIHMr, Jaipur. Okay, now it is the second prize. And the second prize has been tied up. And one is Dr. Deepak Yaduvanshi and Akshita Saha from Soni Manipal Hospital, Jaipur. And also the joint winner is Siba Birda Sharma and Barsa Patil from IIHMr, Jaipur. And the first prize goes to, any guess? First prize goes to, okay, it's a brain death declaration. That is Dr. Susma, Dr. Pathak, and Dibangsu Sharma from IIHMr, Jaipur. Thank you. Thank you.
Just one manager.
You're next. Thank you very much, everyone. A word of special welcome is due to our guest of honor today, Mr. Samuel Maunganitz. We are delighted by your presence, sir, and we really appreciate your high level of engagement every year. We feel that you have become an elite member of Team Pradanya, and together we are making measured progress towards the conference year after year. It is a privilege to have you, and I request you to kindly grace the event with your valuable words.
Respectable members on the dais and respectable participants to this Pradanya 2015. Definitely it's a great honor to be here and for you to say it rightly, my surname. Fantastic. And one of the things which she came to me and asked, are you ready for it? I said, no, I'm not ready. But there's another gentleman, it's so difficult to say no to him, which is Dr. Josh. Dr. Josh is one of my big enemies. On Friday, I just came back from Africa after 2 months break. And just the moment I went through the immigration, I put on my cell phone. And the first call I receive in India is that of Dr. Josh. says, "Are you on the road?" I said, "Which road?" "I've just landed, sir." "The road to Pradanya." I said, "What?" "No, you agreed 3 months ago." 3 months ago? "No, I didn't know. It wasn't me." "You did. Even your team members are coming." "Oh, your team members are coming. You even signed a letter before you left." The road you have been discussing over the last 2.5 days is full of darkness. There are certain conditions which must be fulfilled. And I share with you 4 wise people. First one, it was called Alice in the Wonderland. How many of you have read the book of Alice in the Wonderland? Possibly none. That's not very good. You go back to class 5. Alice in the Wonderland actually was there where there are 4 roads, 5 roads, and asked, which road do I take? Is it the 2020 road map? Which road do I take? And this little Vincent, which was just one of those roads, came out in the bush and said, well, it really depends where you want to go to. Otherwise, any road will take you there. So it really depends with the 2020 where we want to go to. Otherwise, we are actually going aimlessly. And many of us, we are doing this in our environment. We are lost when we come to many roads, and many of us never work it out when there are so many choices. That's Alice of Analysts, the if and then. It depends with your destination. That's the if. Then you can choose the right road. The next one actually is Albert Einstein said, that really means we need to have a theory which is proven by an experiment. If you tell me that this is the point I have to go, and I have to go this way, that means it has to be proven. When we are coming to this place, we use this road, I think it's Tong Road behind me, it must be Tong Road. And that side is blocked. There is an obstacle. We made a U-turn. Because the condition was not favorable for us to come through. Despite being the right road which we chosen, there are constraints on this road. You have to know those conditions. So the driver was so smart enough, he just made a U-turn, and we came the other way. It was longer, but we were able to get here. And what did he actually say? He proved the point that with an experiment, I have to prove the theory it works. No path will ever lead from an experiment to the birth of a theory. You can't actually create a theory from an experiment. You have to come up with an experiment which is based on a theory. Ladies and gentlemen, I hope in these 2.5 days you've come up with a number of theories of solving some of these bottlenecks which was there on this road. I hope you have this number of bottlenecks. The other one we actually put in was Archimedes. He says, if you give me a liver long and strong enough, and a fulcrum on which to place it, then, if you give me the liver and the fulcrum to place it, then what? What did he say? Huh? Then what? You guys have to read some of these theories in order for you to make it. Then he said, then I shall move the world. If you give me the liver, the fulcrum to hold on, I shall move the world. How big is the world this gentleman was saying, I want to move it? That world is almost the same as that of the health when you come into universal health. It's so huge. It depends with the lever which you're using. It depends with the fulcrum which you're actually putting it on. And it depends with the effort which you're actually having. But all these would also mean you are part of that change that brings the last guy on the tree, that is Gandhiji, be the change. Now, what do we mean by being the change in this Pradanya? It means, for me, I know many are saying don't go for competition. The only thing I like about you students, especially you from IIHMr, every time I'm coming here, you're always doing this to me, trying by all means to outsmart me. That's not very good because of the age difference. You know that? I'm a bit of a senior citizen. So this outsmarting which you're doing is very much acceptable because it keeps us really afresh. What is it when I talk about all these theorists? Definitely there's something good about theories. If it can be proven, what do we want to prove under this? 2020? I looked at some of you and then asked a few of you, how many are in IIHMr as a student in 2020? Raise up your hands. In 2020, who are students in IIHMr? None. You see how creatively you are, outsmarting us. That by 2020, vision comes in, which will be happening when you are no longer there. Hey, so who is going to prove the point if you guys have run away? Why did you put 2020 when you are no longer here? We wanted to come back with your theories and challenge you. You said in 2015, it's going to happen if you follow this, and we come in 2020, none of you is around. Your theory was very good, but we're going to follow up with you. What do you want to be in 2020? I asked one of you. I want to be CEO of a big hospital. I want to be like you. Oh my God, you say, don't come to this position. It does not make a difference. Right? I want really to be at that level. I said, okay, you can do it. And I said, where are you in 2020? I'm there. There are three things we are asking for this road, and the universal one, that of being in 2020. 2020 for every age. For every person, whatever the age, wherever that person is, that's the 2020. What we want? Three things. Then you shall say, aha. Are you able to say aha? Say it out. Aha. Aha. She said, aha. In 2020, what will we be saying, aha? You shall all be alive. If you are dead, 2020 was not a road for you. Universal health coverage was not for you. You are dead. We don't want coffins, we don't want cemetery, we don't want places where people will be bad. No. So our road, if it does not lead to being alive, forget it. These 2.5 days have not been of any value to you guys. So what is that which is needed to be changed in order to be alive? I'll leave it up to you. go back to every presentation and put these preconditions, these prerequisitions, and you find out which ones are required to be alive for every newborn who is not yet born, for every adult who is actually there. So it's be alive. That's the first A. Your aha is already being made now. The second one, many of us would like to be alive for sure. But the presentations I had when I came in, I came actually for lunch, and then I was caught and said, you have to now talk because you have eaten our food. So, I mean, if people have to pay, we're eating, and then that's not very good. But they said, yes, you have to do that. The second one is actually healthy. Be healthy. Don't be just alive if you are not healthy. Okay? You have to be healthy. What is the requirement? What are the preconditions? What are the prerequisites for you to be healthy? To be born healthy, to be growing healthy, to be actually surviving healthy. You are talking about all the cost. Is it one of the preconditions that it should be affordable? You are talking about the foods which we have. Is that the precondition which it must be? We don't know. And maybe the right thing, but you already know it. That's what our session of this year actually was proving, bringing to us. So it's really looking at this whole issue of swastika that it is very, very important. Oh, what is the first one? What is alive? Jetarao now? What is it, Jetarao? What is being alive? You don't even... What is the Hindi word for being alive? Zinda. No, that Zinda is just alive. Be alive. Zindarao. Zindarao? Jindarao, okay? Say, is that what Jeterao? Is that? That's good. Okay, and then the other one is swastika, no? So that's the noun. Now you're going to have come up with now A and H, huh? So we are at the A. We're not yet at the aha. What is the last A? We have A, H, A. The first A, be alive. The H, be healthy. What is the last A? Yeah? There you are. It has been said, yes, by 2020, if we are moving towards the universal coverage, if we are moving towards, it's unfortunately not a destination. It's a pause. It's a milestone. The 2020 is just a milestone we are actually going to reach when we go on this road. The last one, the A. Ladies and gentlemen, when you're out there, be active. Be active.
Be close to achieving Millennium Development Goals that we had set for ourselves. And I'm sure this we will maintain and better upon what we have been able to do. And there's now the wise people again coming up with new jargon, sustainable development goals. So there is no end to developing goals for ourselves because health is always ever improving phenomena. What is final health, we don't know. Somebody has to understand this. But he has also pointed out some very important things. How do we go up there? Will you be there? Do you own it, what we are talking today? But there are theories. And he asked a very important question, rather brought us that issue or concept of liver and fulcrum. We need a liver. But to me, I think we all have studied physics. Liver is very important. So strategies we have. But where we put the fulcrum? So we maximize leverage from our strategies or theories or evidence that we have. That is a very critical thing. I hope we will find out. We have always been trying to find out. We have levers, but we always keep on discovering where is the fulcrum. that maximizes the outcomes and gains of our strategies or actions that we do. So, but we are very delighted that we could really bring home the major drive now of universal health coverage. As I said on the day one, that it's not a new idea. It's a new push that we are giving. The push had come in 1978, same old ideas. But we need to keep on reminding us always that we need to still achieve a lot. So this universal health coverage is again to push forward the basic need of primary health care to all. So we talk about access, we talk about availability, we talk about affordability, and we talk about equity, which is so important. I think why we are talking, because we have not been able to achieve it. There's so many people deprived, rich, poor, rural, urban, backward, forward. They have different issues. Forward have different issues. Backwards have different issues about access, availability, and affordability, and very importantly, quality of services. We have also talked about the operations issues. How can we take the services down to the people through the systems? How we can build our systems. We already have systems. It's not that we are without systems, and beautifully designed. I must have shared some time that India's healthcare network and system is probably the largest. But how the system works, perhaps it's not efficient and very effective. So friends like Saumitra, who talked to us on blue ocean strategies, they are very much needed. These are brave people who try out. I remember he came to me 2-3 years back with his ideas. And Dr. Joshi was also sitting, Dr. Mangal was also sitting. Maybe Dr. Mangal was not there. But we showed our skepticism of working with the government and succeeding. But I tell you, persons like him are needed. Coming with enthusiasm, coming with, mindset that we can do it. And they could make it happen. They looked at the opportunity, and fortunately the opportunity started knocking when he came in the last Pradanya. And he shared his views and ideas and the technologies that he wants to bring to Rajasthan. And incidentally, the secretary was sitting here. And he jumped on it, and then it's a history. So we need to keep on exploring the opportunities. We need people who have confidence, who can go through the ordeals of the system, because everybody tries to block you, that this is not possible. This cannot happen. This is the regulatory affair. This is against the law. This is what, this is that. So many things will come. But I think we need to break through all these hurdles and make the things happen. We may succeed, we may not succeed. It's okay. But we need to try it out. Why we should not succeed? Why we should not succeed? But I think we succeed. In the project mode, we do succeed because we put our all might into it. All our technical abilities, all our interventions, communication, resources we put to make it successful. I think the issue then comes is, and I tell you, if you look at the site, and I am part of that, this National Health Resource Center's portal of innovations, you will see so many. And I was in a conference 2-3 months back, National Summit for Innovations in Healthcare. It was organized by government. All health secretaries, mission directors, and so many people had come over here. The hall was twice the size of this hall and was packed. So right from Health Secretary of Government of India down the line, those who were implementing the programs, they were all there to share innovations. Yet the question comes, can we scale? Let us prepare ourselves to scale up. Let's prepare ourselves to sustain those actions, and that will give us the rich dividends. Well, we have the main business of generating, creating new knowledge, or creating knowledge otherwise, and also produce people with talent who can deliver, who can think like this. I think it's very, very important. Mindset is very important. And I think self-confidence is very important. Everything should be possible, I believe. And I think this conference gives us a message. So it covers the areas which are the thrust areas of the day and for the next 10 years. It's not only 2020, it's going to go beyond maybe 2025 or so. And let's hope by 2025 we get it. So I think at the end of this, I feel very satisfied with the way we have gone in. So many people, so many friends came in to support us in this particular conference through their intellectual capacity and their experience and sharing with all of you and with us. I think it was a very, very rich conference from that point of view. This year, I have discovered a person, and I want to thank him very profusely. And this is Dr. Vijay Raghuvanshi. Where is he? Where is he? Oh, I'm very happy about him that he has come out. We have Dr. Puri, we have Dr. Joshi, we have Dr. Mangal, we have everybody with us. But this new discovery that I have, that who can lead from front and always giving me this confidence, don't worry sir, I'll do. Don't worry, we'll take care of it. I had never seen this Raghuvanshi earlier. Thank you so much. And congratulations for this. I like to congratulate all my faculty colleagues who continuously supported our students and those who are preparing for posters and their research papers for presentation. I was very delighted to see that so many posters, so many research papers have been presented. And I saw the crowd around the posters. Generally, I don't see crowds on the posters. But I'm very happy that people tried to understand what has been presented on the posters and all this. So let me thank you all students for very actively participating in this conference and contributing to this. I may miss many names because I think everyone knows here I'm quite forgetful about the things happening around me. So, but I wish to thank everybody for being with us during this and throughout the preparation of this conference. I wish to express our deep sense of gratitude to our academic partners and helping us with money, and also it will not happen with me. So our partners in this, I want to thank everybody. And in my office, I'm a loner. But you might have noticed I sit outside my office. Have you noticed this? Why do I sit outside my office? Because I want to remain connected to you all. Because when you come to my office, my secretary would never allow to come in. That's why I sit outside and I keep on moving around, because my main thing is to connect with you and help you to grow. I want that you should learn, you should grow. And this is one exercise, and I want to remain connected with you. So we need to come out. The message, the message is open up, come out, meet with people, have good ideas, share your ideas, help each other. That's what we need to do. And that's how IIHMR culture has been built upon. That's how we have built this culture. And the culture is the uniqueness of IIHMR University. I believe and request, make an appeal, let us continue and create and strengthen this culture. With this expectation and hope, let me thank you all for being with us in this conference, making it successful. You need to be rewarded. Tomorrow is closed.
Thank you. Thank you.
Thank you, sir, for being a wonderful mentor today and always. Moving to the next dignitary, who has been a part of the IIHMR family for more than 12 years and has now become the heart of this institute. With his continuous and selfless efforts, he has innocently paved career paths for numerous people. We call him our gentle powerhouse, a source of inspiration for all students. Any description would be inadequate for him. Ladies and gentlemen, please welcome Dr. Suresh Joshi for a vote of thanks.
Thank you very much. Indeed, Dr. S.D. Gupta said that it's difficult to talk after Sam. Imagine Sam and S.D. Gupta and then this Safed Balwala. I can only thank Sam by saying, aha. I pledge this that 2020, I will do aha. I will thank Dr. S.D. Gupta. I'll thank Dr. S.D. Gupta because for next 5 years, all IIHMR graduates should say SDG. SDG is Shiv Dutt Gupta. So everybody remembers Shiv Dutt Gupta. Sustainable Development Goals is S.D. Gupta. That's the value Dr. S.D. Gupta wants to give to all our young professionals. I was a student in 1976, a student of Dr. S.D. Gupta. He was my guide in my MD. And Sam says, I'm his guide, so he's super guide. So S.D. Gupta Sahab is a super guide. Okay. Dr. Puri said, after such a long time, I came to know what Pradanya is. And he said, Pradanya is wisdom. Huh? But the operational definition of Pradanya is by the students, for the students, of the students of IIHMR. It's an operational definition. It's an operational definition of Pradanya because this conference of 3 days is because of students of IIHMr. By the students, students made this conference so big by making so many presentations. Students made this conference so effective because they invited such a galaxy of experts. Students made this conference a success because they made spotless, errorless conference facility. Thank you very much, all of you. And I will fail my duty to express my gratitude to the ones who are behind the scene. Those who are not in jackets and ties and beautiful dresses. Those who are doing hard work. The drivers, the administrators, the persons who were arranging this, the hotel people, all need a big applause. Thank you very much.
Thank you, sir. I think we all appreciate opportunities like Pradanya that help us to harmoniously work together, achieve together, and think together. On behalf of the IIHMr University, I thank you all for your presence. This may be the end of this year's conference, but undoubtedly a new beginning. We look forward to meeting next year with new developments and deliberations. I request Dr. S.D. Gupta to present a memento to our guest of honor, Mr. Samuel. I request Dr. Joshi to give a memento to Dr. S.D. Gupta. I also request Brigadier Dr. S.K. Puri to give the memento to Dr. Joshi and Dr. Anup Khanna. I also request Dr. S.D. Gupta to give a memento to Dr. Vijay Pratap Raghuvanshi. Thank you everyone for being with us. You may proceed towards the hallway for tea now. Just one announcement. I request all the faculty members and Pradanya volunteers to be here for this photography session. Thank you.